Welcome back to Clinical Pearls in Practice, the podcast where we break down real-life cases and help you master the key points for your boards and bedside.
Today's case is about a 36-year-old male who's planning his second ski trip, but his first one didn't go quite as smoothly as he hoped.
Let me paint the picture. Last year, this patient went skiing for the very first time. He made it to the top of the mountain, probably feeling pretty accomplished, and then bam, headache, nausea, and dizziness hit him.
Classic triad right there. Now, importantly, he had no respiratory difficulty. That's a key detail we'll come back to. And that night, he couldn't sleep.
Fast forward to this year, he's coming to your office asking, "Doc, I want to go skiing again, but I don't want to go through that misery. What can I take to prevent it?"
So the question is, which medication should he start the day before his ascent and continue until his descent is complete? Your options are acetazolamide, aspirin, dexamethasone, tadalafil, or zolpidem.
Let's break this down. First, what happened to this patient last year?
He had acute mountain sickness, or AMS. It's the most common form of altitude illness, and it typically occurs above 8,000 feet. The classic presentation is headache, which is actually required for the diagnosis, plus at least one of these: nausea, vomiting, fatigue, dizziness, or insomnia.
Exactly what our patient had. Now, here's what's important. He did not have respiratory difficulty. That tells us he didn't progress to high-altitude pulmonary edema, or HAPE, and there's no mention of altered mental status or ataxia, so no high-altitude cerebral edema, or HACE.
Right, so we're dealing with straightforward AMS prevention. Now let's go through these options.
Starting with zolpidem, that's Ambien. Sure, it might help him sleep better at altitude, but it does absolutely nothing to prevent the actual mountain sickness. That's not our answer.
Aspirin. Some people think, oh, it's a headache, let me take aspirin. But aspirin is not recommended for AMS prevention. It won't address the underlying pathophysiology.
Tadalafil is interesting. It's a phosphodiesterase 5 inhibitor, and it actually does have a role in altitude illness, but specifically for high-altitude pulmonary edema, or HAPE. It's a second-line agent after nifedipine for HAPE prevention and treatment.
Our patient didn't have any signs of HAPE, so tadalafil isn't the right choice here.
Now, dexamethasone, this is where it gets a bit tricky because dexamethasone is used in altitude medicine. It's a first-line treatment for acute mountain sickness of any severity, and it can be used for prevention.
But, and this is the key point, it's a second-line drug for prevention because of its side effect profile. We're talking about potential issues with hyperglycemia, mood changes, immune suppression, and other steroid-related effects.
Exactly. So, if we have a better option with fewer side effects, we should use that first.
Which brings us to acetazolamide, also known as Diamox. This is the correct answer and the preferred agent for preventing acute mountain sickness.
Let's talk about why acetazolamide works. It's a carbonic anhydrase inhibitor. What it does is cause a metabolic acidosis by promoting bicarbonate excretion in the kidneys.
And that metabolic acidosis stimulates ventilation, which increases your oxygen saturation at altitude. Essentially, it helps you acclimatize faster.
Multiple randomized controlled trials have demonstrated its efficacy. The typical dosing is 125 to 250 milligrams twice daily, started the day before ascent, and continued for 2 to 3 days at altitude or until descent.
Now, what should you counsel your patient about side effects?
The most common is paresthesias, tingling in the fingers, toes, and perioral area. It's annoying but harmless. Some people also notice that carbonated beverages taste flat.
And because it's a diuretic, patients will urinate more, so they need to stay hydrated. Oh, and it does have a sulfa moiety, so in patients with severe sulfa allergies, you'd want to be cautious, although true cross-reactivity is debated.
So, let's bring it home. Our 36-year-old patient had classic acute mountain sickness last year. This year, to prevent recurrence, we're recommending acetazolamide starting the day before his ski trip and continuing through his time at altitude.
And let's not forget the non-pharmacologic measures. Gradual ascent when possible, avoiding alcohol, staying hydrated, and recognizing early symptoms.
Perfect. So the clinical pearl here, acetazolamide is your first-line prevention for acute mountain sickness. Dexamethasone works, but is second-line due to side effects. And remember, tadalafil is for HAPE, not AMS.
Great case. This is definitely a board favorite and something you'll see in primary care, especially if you practice near mountain ranges or have patients who travel.
Thanks for tuning in to Clinical Pearls in Practice. Until next time, keep learning and keep those clinical pearls close.